First of all, thank you for this kind invitation. And after this marvelous presentation, I want to share our perspective. And mostly I'm going to talk about the on-site evaluation during the fine needle aspiration. Of course, pancreatic fine needle aspiration has many advantages within the high sensitivity and specificity for malignancy, which reduces the need for more invasive procedures, and additionally allowing rapid on-site evaluation enhances adequacy and further improving specificity and sensitivity. Moreover, it's facilitating the ancillary studies such as molecular testing for inoperable patients. But of course, it has challenges and limitations, which Dr. Asay already mentioned about the cystic lesions. And actually, cystic lesions are particularly the most challenging area for us. For example, if you see the mucinous epithelium and the endoscopist needle passes from the stomach, those cells may represent the gastric epithelium. And if the cyst does not have any solid area, rapid on-site evaluation may not be informative too. And second entity is chronic pancreatitis versus neoplastic processes. What we observed in the chronic pancreatitis is often non-specific, and however, in the peritumoral area, peritumoral fibrosis can present as similar as we can see in the chronic pancreatitis. And those are our most challenging areas. Of course, material adequacy is one of them. If you have an on-site assessment, even the benign acinar cells may be considered sufficient, but if you cannot have rapid on-site evaluations and malignancy is suspected, those acinar cells may be deemed inadequate. And the last thing is clinical information. Of course, if you have an on-site assessment, you can able to learn where the needle passes, the prior malignancy of the patients, and those are the critical diagnostic clues. So therefore, I'm mainly talking about rapid on-site evaluations. Actually, the most important task during the rapid on-site evaluation is the specimen adequacy. And of course, if in the challenging cases with unclear clinical presentation, defining adequacy is more challenging. But if the cancer diagnostications in the rapid on-site evaluation, we can require further tumor classification, or we want more passes for performing molecular or biomarker testings. And not in our country, but on-site adequacy assessments can be performed by certified cytopathologist. But in our country and in our institute, this is performed by the pathologist. So how to perform? I think this is the most important area. Actually, direct smear preparation is the primary method for preparing this. And generally, we aspirate the samples typically on a glass slides. And even the distribution or patterns of the cells in the smear can provide many information about the characteristic of the lesion. For example, epithelial tumor cells tend to clusters, whereas hematopoietic tumors or melanoma exhibit a single cell distribution. And even the artifacts, smear artifacts, can be useful diagnosing lymphoproliferative diseases like large cell B lymphoma. So how to prepare? I think this is important because sometimes we don't have enough experienced technicians. You know, one of them is the one single slide smear technique. We just put the aspirate in the center of the slides, and we are using a second slide for a spreader. We call the spreader slides. And we hold the sample slide and pull the spreader slide towards the end of the sample slides. And this technique enable to produce just one slice, and the spreader slice usually contains little or no cellular material. And the other one is two slide smear techniques, which we have a large amount of sample. And now in here we use the two slides, and we aspirate the slide below the center and align a second slide on the top of the sample. And we gently pull the sample slide and the second slide. And with these techniques, we can able to obtain two slides containing similar amount. One we use for the diff quick rapid on-site evaluation, and we can use the second slide immediately fixed in the alcohol, and then later use for pulp staining. And actually, timing is very important because if the aspirate is thick, you may need to wait a while before the smear process to allow. but the aspirate is fluid. Excessive tension between the slides may prevent you moving them properly. Therefore, timing is important. And no additional force should be applied because I already mentioned about the smear artifacts. We can using those artifacts for diagnosing. And the tension between the two slides should be sufficient to help break the aspirate. So what about those cells? Actually, so how we should break the sample? For example, in this example, if you directly smear this example, probably you will see only the blood. The key point, there are tiny little fragments in the blood clot, and we should spread those little clots in here, which I round them in here. And as you can see in this blood sample, we have transparent, cream-colored, tiny little fragments. Actually, we perform a study about that because we have a very experienced technician, which is also a cytopathologist. He first looked the slides, he examined the transparent cream-colored particles and the others like the presence of necrosis and color and consistency. And with this technique, especially there is a name, macroscopic on-site evaluation. And actually, if you do not have a rapid on-site evaluation, with this macroscopic on-site evaluation, you can able to obtain enough material for diagnosis. But for example, in the last example in here, we see a lot of fragments in here. Of course, we have enough tissue for diagnosis, but mostly the tissue fragment contain of fibrosis. So it cannot is enough for diagnosis, but it's insufficient for molecular tests. So I already mentioned that this is a time-sensitive process, and we should complete the staining quickly. Therefore, when selecting the appropriate staining protocol, you should decide the laboratory experience, personal preferences, and available resources. And what we are using in our lab is we are using deep quick staining. You can see that there is three regions here. One of them is fixative region containing methanol. Second is eosinophilic solution, and third is basophilic solution. And before we stain we prepare our smear slides. First, we dip the smears in the fixative solution for 10 times. Then we use dip the 30 seconds in the second solution, eosinophilic solution, and for 45 seconds the basophilic solution. Those are not routinely. Generally, you should look and if the staining is completed, because it can vary on the material. Then we evaluate this slides. So how to fix, actually fixation is really important. Generally, we are using formalin solution, and for achieve an optimal diagnostic efficiency, a portion of the aspirate should be preserved for the cell block preparation. And if the rose is not available in your institute, you can store your aspirates in formalin or ethanol, methanol-based fixatives. And if you are suspicious for any hematopoietic neoplasia, you can use RPM medium because they preserve the cells better, and you can able to send your material to flow cytometry analysis. So what about our experience? During the third and a half year, our experience, 600 AUS patients we have performed with the rapid on-site evaluation, and the average pass number is 4. And just the 5% of them is non-diagnostics. And when we looked if the 20% of those cases had more than 6 passes. So when we evaluate why we perform 6 passes, more than 6 passes, half of them diagnosed with malignancy. It doesn't mean that we don't have enough diagnostic material, but in our institute we have been widely using molecular tests. Therefore, if the patient is inoperable, we want more passes for performing additional molecular tests. And just 10 of them diagnosed with APSA, acute pancreatitis or chronic pancreatitis, and 8 of them were non-diagnostics, and 24 of them were benign. And before I'm going to finish my presentation, I want to show you some cases. For example, in here, there are numerous cells in the background, and the sample appears helicellular. And when we look to the higher magnification, most of those cells showing the monotone, similar looking. And in these cases, adequacy was given in the second pass. And when we look to the macroscopic appearance of this lesion, you can see this round, cream, well-circumscribed lesion in here. And the microscopic appearance of these lesions, you can see that this is a well-defined border. There isn't any fibrosis present. It's entirely composed of neoplastic cells. Therefore, it's easy to obtain more cells during the AUS. And what about this case? There are few cells in the background, and nearly all of those cells are benign. Let's zoom to the red circle area. And in the vicinity of the benign pancreatic tissue, which we are seeing in here, benign pancreatic tissue, we have those two highly atypical cells, and we call this malignant. And even we obtain those cells in the 15th pass in these patients. And when we look to the macroscopic evaluation, even in the resection specimen, the lesion boundaries are not clear, indistinguishable, and within such a large tumor tissue area, we have only just few adenocarcinoma clusters across the nerve, around the nerve. Therefore, the likelihood of the needle capture these is very low. So we have a big mass with cream-shaped, ill-defined borders, and we have a lot of numerous tumor cells forming these clusters, and therefore likelihood of the needle capturing this area is higher. So what about the ancillary studies? We can perform immunohistochemistry, biochemical analysis, especially for the cyst fluids, which we do not perform in our institute, flow cytometry for the patients suspected with lymphoma, and molecular analysis, which we can able to detect mutation, fusions, and other genetic alterations. As you can see in this table, there are a lot of genes, and this table is for especially for the cystic lesions. Those are not specific. We can see the KRAS mutation even in the MCM, IPMN, and TP53 in the IPMN with neoplasia or MCM with neoplasia. But we can able to get enough knowledge from those alterations. But what we are doing in our institute is performing molecular tests, especially for the single cell nucleotides or the fusions, for finding treatment options. We can widely using smeared slides for this purpose. And I'm going to show you, this is my last slides. You can see this is beautiful adenocarcinoma in the smear slides. And then we look to the cell block. Even you can see in here, we have a big, large cores in here, like probably this belongs to a fine needle biopsy. And when we look closer, you can see the malignant cells in the fibrotic tissue core. If you ask me, are you going to use this for molecular tests? Probably. I will say that, okay, we have enough cells, but the fibrosis can inhibit the molecular studies. But when we look to the background, we have those detached adenocarcinoma cells. Probably those cells giving us more quality nucleic acid, and we can able to perform molecular tests. Therefore, we have to perform more studies about which is better for the molecular test, FNA or FNB. And thank you for listening to me.